I will be your MC today, as well as your timekeeper, because we're going to try to take full advantage of the time we have together today. As for our agenda, we will hear first from Crystal Adams with some of the lessons learned, conclusions, and follow-up from our 2022 Oral Health Day. Then we'll welcome Dr. Kathy Colville, President and CEO of our very own North Carolina Institute of Medicine. As many of you know, Dr. Colville and her team have been conducting a oral health task force on Medicaid and transformation in North Carolina. It has involved 60-some participants, and we're in the second phase of that task force work. That is a partnership between the North Carolina Institute of Medicine and Foundation for Health Leadership and Innovation, and funded by the Duke Endowment. I think you'll be excited to hear what she has to share about her observations and recommendations. And then after that, we have an excellent group of panelists, each with their own unique perspective on the oral health issues facing North Carolina and their experiences as they react to what Dr. Colville has presented. And it'll be a time for you to ask questions, and Hugh Tilson will be our able-bodied moderator for this portion of the event. Just a reminder about our technology that we're using today. All participants are in listen-only mode. Please use the Q&A function on Zoom to ask your questions. We have people who will be watching the Zoom Q&A and passing those questions along to our panelists and moderator for their information. If your question does not get answered today, never fear, we will follow up with you after the event. We also have our resident technology expert, Brady Blackburn, standing by. If you have any technology issues, please reach out to him. So now we want to get started. I'm excited that we have such a strong group of participants here today, and we look forward to your interaction and participation in the event. Now I'd like to introduce Crystal Adams. Crystal is known to many of you, I know. Crystal joined the Foundation for Health Leadership and Innovation with the North Carolina Oral Health Collaborative in September of 2021. After a long and distinguished career in dental hygiene and dental assisting, she is credited with launching the first accredited dental assisting program at the Catawba Valley Community College, CVCC. She has been a proponent of school-based programs. She has been a president of the North Carolina Dental Hygiene Association, and she has worked tirelessly to improve oral health in North Carolina. We are delighted to have Crystal with us this morning to talk a little bit about the Oral Health Day from 2022. Take it away, Crystal.
Thank you, Steve. I'm going to share my slides now so we can get started. Give me just a second, of course, with technology. Okay, so as Steve mentioned, my name is Crystal Adams, and I'm the director of the North Carolina Oral Health Collaborative. And we are going to just do a recap of last year's Equity in Action 2022 Oral Health Day. So for those of you that are not familiar with the North Carolina Oral Health Collaborative, and for those of you that are familiar, I just want to say that our mission is centered around oral health equity and access to care. Our ongoing work in North Carolina, not just from the North Carolina Oral Health Collaborative, but other stakeholders in the state, includes policy changes, the school-based oral health programs, North Carolina Institute of Medicine's Oral Health Transformation Task Force work that Steve mentioned earlier, the Community Oral Health Transformation Initiative focused on value-based care, which includes many clinics throughout North Carolina, and also the many care coordination models that the safety net providers have initiated in their clinics. However, as we all know, there are still challenges that exist, and that there is data that shows that there's significant oral health challenges in our state and across the country. So what are we going to do about these challenges? Collectively, and I'm sorry, let me share my screen, and I'm not in slide mode, excuse me. So alone we can do so little, but together we can do so much. And we learned last year in our solutions workshop that it takes everyone in North Carolina to move oral health policies forward, to make changes in the states. So just to review last year's Equity in Action event, we had 3 objectives. We wanted to raise awareness of the systemic inequities in oral health care across the United States and in North Carolina. We also wanted to hear your voices. We wanted to hear opportunities to reduce and eliminate these inequities for oral health care access and outcomes. And that was successful through those workshops. And we wanted to inspire all of you to take action. We need your voices at the North Carolina Oral Health Collaborative to make these changes in our state to improve access to care and equity in oral health care. So, of course, as like today, we had a phenomenal panelist, group of panelists, experts in oral health care. We had a great variety of diverse attendees. So this is just to overview the many voices that we heard from last year. We identified priorities and strategies, and we identified 3 buckets of work that we need to work on in North Carolina. Those included workforce, access to care, and payment reform. I want to review each bucket of work of things that arose last year from those workshops, because I think you will hear many of those today come up. In the workforce bucket, of course, we've heard many times the expanded dental hygiene scope of practice, allowing EFTAs, which are expanded function dental assistants, and we need to prepare quality dental assistants. Incentivizing dental professionals to work in public health, because that is where we're going to serve the marginalized communities and the ones that have not been able to access oral health care. Incorporating programs in dental schools that promote graduates to work in our rural communities in North Carolina. Creating programs for our oral health advocates, our navigators, our care coordinators that can connect the public to oral health care. Preparing dentists to treat the IDD population. We need to work on recruiting diverse faculty and future dental professionals. Promoting minimally invasive care, and that has been in some of our work with the court initiative that I mentioned earlier. Improving salaries for dental public health care providers. And of course, we all know we need to establish a pipeline of dental professionals. And in order to do that, we're going to have to reach out to our middle schools and our high schools and engage people from rural communities to start thinking about dental professional opportunities. In the work of access to care, many of your voices actually talked about the need to increase the use of teledentistry and minimally invasive care procedures. Many of the communities and many of the clinics in our state are doing that now. Some of you are starting that work. Also utilizing mobile dental services in more settings. Continuing to build opportunities to connect with and teach parents how to apply fluoride varnish. Fluoride varnish is something simple that they can actually apply to their children's teeth and help prevent decay. And we can do this through synchronous teledentistry modalities. We need to collaborate with our medical professionals. Whenever we think about oral health care, we think about just the mouth, but our mouth is the gateway to our body. And so we need to think about including that in the whole person health. We also need more data. As I mentioned, data shows that, there's a lot of challenges in oral health care, but we need to continue to collect that data to see where we stand in North Carolina so we can provide better care to our marginalized and underserved populations. The next bucket of work that I want to review was payment reform. We need to secure reimbursement for these care management or care coordination services that have been incorporated in our safety net clinics in North Carolina. We need to understand the benefits and challenges of Medicaid participation. We know that it's a complex system, but we do feel like we can make it a little bit easier on the public in addition to healthcare providers. Encouraging providers to transition to the health information exchange system and including dental in that. I know that's a complex system that we're going to have to work out those challenges, but in order for us to connect to the medical professionals, we need to take part in that. Advocating for North Carolina Medicaid to pay for sealant reapplication and intraoral pictures. Supporting the transition of oral health care delivery, emphasizing value-based care. We need to concentrate on that personalized care for our patients and creating diagnostic codes for dentistry. As medical has, we actually just code for procedures. We need to be able to diagnose what's going on in dentistry. Moving forward, we have a lot of work to do, and many of the voices that we heard from last year and a lot of the work that we're doing this year that continues to elevate in the work that we're doing. Some of that is going to be with the court initiative focused on value-based care, the patient advocate initiative, which includes the care coordination, the care management, and of course, the North Carolina Institute of Medicine work with the task force and the recommendations that will be coming out in the near future. So at this time, I would like to pass it back to Steve and thank you for this time and in joining me in recapping from our work last year.
Steve, you're still muted.
Thank you, Crystal. That was an excellent summary of our event last year and the workshops and the information we got last year. And you can see that it is helping to guide our work today. So the message we hope you hear today is by participating in Oral Health Day, you are giving us important feedback, suggestions, and ideas about how we can improve oral health in North Carolina. So please be open and share your information because we're listening and it helps guide our work. The next item on the agenda is our keynote presentation, and I would like to introduce Dr. Kathy Colville to all of you. I'm sure some of you know her already, but Kathy earned her bachelor's degree in comparative literature from Brown University and her master's degrees, plural, in both social work and public health from the University of North Carolina in Chapel Hill, and then her PhD in public administration from the North Carolina State University, where her research really focused on policy process and the Medicaid program. So before that, Kathy led the Department of Healthy Communities with Cone Health, one of the largest health systems in the state, and focused on most vulnerable members of the community in Guilford, Forsyth, Rockingham, and some of our central North Carolina counties. We really appreciate Kathy being with us today. And I've already mentioned she is leading the effort around the oral health task force that the Institute of Medicine is conducting. And we're going to hear some of her insights into what that work has taught her so far. So welcome, Kathy, and we look forward to your comments.
Thank you so much, Steve, and thank you so much, Crystal, and to Foundation for Health Leadership and Innovation and the North Carolina Oral Health Collaborative for the opportunity to talk with everyone today. I'll note before I begin my remarks that we do have one extra special person who's listening today. I want to give a shout out to my mom, Ruth Colville, RDH, who worked for decades as a dental hygienist. She is a 1967 graduate of the dental hygiene program at The Ohio State University. And I always like to tell people also that her class rank was 1 in that class. And I want to appreciate my mom for helping me to understand from an early age the importance of oral health. But I know there's all kinds of very important people in this audience. And again, I'm grateful for the opportunity to talk with everyone. But coming back to family again for a little bit, last week my older brother was in town. He lives out of state, so it's really fun when we get a chance to be together. And he and I had one of our periodic phone calls with our Aunt Ann. Now, my Aunt Ann is now around 82 or 83 years old. I don't know exactly how old she is. And while I understand that like 60 is the new 40, I think that we also all understand that by the time you've reached 82, 83, you qualify as truly senior in life, and hopefully you have all that attendant wisdom that comes with aging. So my brother and I turned to her and we were asking her a whole bunch of questions, some of those existential questions, and it was a neat conversation. But we also asked her if she had any guidance for us at our ages from her perspective on life and her many years on the earth. And she did. And Aunt Ann always has an opinion, and that's a good thing. And here's what she said. Keep your health. That's number 1. Teeth are important. And she had some other things to say about education and children and so on. But when she said that, I just laughed to myself because it came immediately out of her mouth. It was blunt. It was clear. She had these short staccato sentences, and this is the wisdom that she wanted to share with the next generation. Keep your health. That's number 1. Teeth are important. And I thought, you know, it's pretty simple advice on the one hand, but I want to unpack that a little bit. Now, my Aunt Ann has not been serving on the North Carolina Institute of Medicine's task force on oral health transformation, but somehow she knows, she's absorbed, and she understands the main message. Oral health is health. Keep your health. That's number 1. Teeth are important. She gets it. In fact, I just want to point out that she had any number of different possible, and some would say essential, body parts that she could have chosen to talk about. The knees, the heart, the brain, the eyes, these are all important at age 82. But she went with the teeth. And I was not paying her to say that at all. Keep your health. That's number 1. Teeth are important. So I know there's a lot of professionals on this call, researchers, people who've worked in oral health for a long time, and they could share with us any number of reasons that teeth, or perhaps if we say it more expansively, the concept of oral health is important. These experts would remind us that oral health isn't just about teeth, tongue, and gums, but really about the whole body. Periodontal disease, as we know, is linked to diabetes, pneumonia, heart attack, stroke, and other vascular issues, pregnancy complications, and possibly dementia and Alzheimer's. But why are teeth so important to an 82-year-old woman who lives in Ohio with her 85-year-old husband, also known as Uncle Bob, and Uncle Bob who still mows the lawn by himself with a push mower? Why is this important to an 82-year-old woman who loves to play bridge, has an amazing garden, and lost far too many friends during the pandemic? Well, maybe teeth are important to my Aunt Ann for the reasons that teeth are important to every regular person. For most people just out there living their lives, the importance of oral health is probably more about being able to enjoy delicious foods rather than understanding that there's a link between oral health and a percentage improvement in cardiovascular biomarker results. Now, I want you to know I'm not knocking heart health. I actually think that improvement in cardiovascular biomarker results is very important. But let's remember that the mouth is not just an ordinary run-of-the-mill anatomical feature. The mouth is the site of activities that are definitive of basically everything that it means to be a human. The mouth communicates. It communicates through utterances that are articulated through our teeth, tongue, and breath that somehow work together to convey both raw emotions and complex explanations of things as varied as the cosmos and dolphins and constitutional rights and the plot twists of Game of Thrones. Our mouths communicate. And the mouth eats, turning amazing things like chocolate ice cream and watermelon and BLT sandwiches into the raw materials that power our lungs, heart, brain, and muscles. The mouth also kisses. We kiss babies when they're shiny and new. And often we're lucky to be there to bear witness, comfort, and kiss our loved ones as they lay awaiting the end of life and the great transition. And we kiss a lot in between, in friendship, in love, and hopefully often and with great passion for the right people. And the mouth also laughs, and sometimes laughs so hard and is so powerful that it affects other parts of the body, like the eyes and the bladder, which can both get leaky when the mouth is laughing really hard. And the mouth smiles and frowns and makes silly faces to try and make babies and 12-year-old boys giggle. And our mouths can do all of these things better: communicate, eat, kiss, and laugh when oral health is present and abundant. So the mouth connects us as humans through these activities, and we realize the loss of connection most acutely when oral health fails or is elusive. So I know that you all know what I'm talking about here. When people pull back on their smiles because they're missing teeth, or they don't like how their teeth look, they don't look healthy, and they don't like what they look like, so they keep their lips closed, cover their mouths with their hands, and cover up those big, beautiful smiles. You know what I'm talking about. It's when people with chronic halitosis plan their movements, and they even design their days so that they can keep a physical distance from other people. It's when people give up some of their favorite foods because they no longer trust themselves to just be able to enjoy them. They're worried about eating those things causing permanent damage to their teeth. And it's also when people feel pain that's so throbbing and cute that doing just the regular stuff, like work and hobbies and family life, is a literal grind. And sometimes the pain is so bad that they feel that they have to give up those things. When oral health isn't present, when oral health isn't abundant, we pull away from each other. So I know that this is maybe a little preachery and sermony than a typical opening to an oral health keynote among experts. I understand that, but I also wanted to make sure that I grounded us in why we all care so much about this. Yes, this is about health, and that's good, and that's what I've devoted my career to. But it's also about human connection and the ways that we shape and support each other. And I think that's why we're really here in the big picture of things. And in the small picture of things, I'm here today specifically talking with you because I'm the president and CEO of the North Carolina Institute of Medicine. And since last August, going on about a year now, we've been gathering smart, thoughtful, and caring people from around North Carolina to think, study, talk, and share ideas about oral health in our state from their particular vantage points, whether that be that of a patient, a provider, a researcher, a payer, an advocate, or a philanthropist, or all or some mix of the above. The fancy term for what we are doing is called policy deliberation. That's what we're doing. We're studying the issues. We're talking with people who have unique and important perspectives on the oral healthcare system in North Carolina, and we're thinking deeply about the policies, investments, and system changes that will help improve access to oral health care and improve the quality of services that are provided to our North Carolina neighbors who use the Medicaid program to access those services. So in case you don't know that much about us, this is the kind of thing that the North Carolina Institute of Medicine does. We are committed to better health for all North Carolinians. And since 1983, via a charter from the North Carolina General Assembly, We've served as a unique connection point between many different sectors. We have a long track record of uniting people to build consensus for actions that will improve our state's health. For the Task Force on Oral Health Transformation, we've brought together around 60 task force members from across North Carolina. We've been learning from Medicaid beneficiaries, providers, researchers, and administrators from across our state and our nation, including oral health leaders from Michigan, Missouri, Virginia, California, Oregon, Ohio, Kentucky, and from the National Office of the Centers for Medicare and Medicaid Services. We've discussed a lot of different things. I'll list a couple of them for you. Provider education and preparation, administrative burden, health data and program performance measures. We've dug deep into areas and questions of equity and access. We've studied the various ways that states have designed benefits and payment. And we've learned about the experiences of Medicaid consumers and beneficiaries navigating our systems in North Carolina. So because of all of this, I am in this particularly interesting position of being basically an outsider to the oral health profession who has had a chance to spend a lot of time learning from and observing the oral health leaders of this state and our nation. It's a really unique lens. I'm so grateful that I've had this opportunity, and it gives me perhaps an interesting perspective on this topic. And I thought it might be helpful to you all to share a couple of my hot takes on oral health from an overly educated outsider. So hot take number one, in honor of Aunt Anne, keep your health. That's number one. Teeth are important. The big message here, which my Aunt Anne gets, is that oral health is health. But very importantly, the oral health system of care is not the same as the health system of care, and that's important. And I think it means a couple of things for making practical recommendations going forward. First of all, oral health and other forms of health, medical, behavioral, and social health, must realize that our individual experience of health and well-being is integrated. It's all happening in one body. And because our experiences of well-being are integrated and interconnected, so must our care be. And as we create and seek to connect better systems, whether they be data systems, information and health records, educational training, or payment design, I think it's important that we can't gloss over the differences in how oral health has evolved as a field in a distinctive way and manner over the past decades. Oral health is funded differently, organized differently, and practiced differently from other forms of healthcare. So we can't take a one-size-fits-all approach. We can't assume that if it works for health system, it works for oral health systems and vice versa. That's short-sighted and simplistic thinking. However, nor can we allow those organizational, historical, and profession-specific differences let us find ways and excuses to retreat to our silos. This is about smart, strategic, and aware integration of systems of care. And the time is now. Hot take number two. If I buy an adult ticket to the 9:30 p.m. showing of Guardians of the Galaxy Volume 3 tonight at Alamance Crossing Cinema in Burlington, it will set me back about $11.50. In 2007, around 15 years ago, the average price of a movie ticket was $6.88. All right, so 15 years ago, I would have paid about $7 to go to the movies. Tonight, I would pay $11.50. So let's play this game again. Undergraduate in-state tuition for 2 semesters at UNC Chapel Hill in 2022-23 was $7,518. In 2007, it was $3,455. So I'll say those numbers again. Last year, $7,518. In 2007, $3,455. So that one's more than doubled. So some of you already know why I'm talking about 2007, 15 years ago. And really, it's because that's the last year that reimbursement rates to North Carolina's oral health providers stopped increasing. According to providers in our task force, we're kind of frozen in time at the reimbursement rates of 2007, 2008. All right, so that sounded crazy to me. But these folks don't lie, so I went to the dental fee schedule archive to verify this for myself. Now, the online archive of the dental fee schedule only goes back to 2011, not 2007, but it's still a useful comparison. And again, I verified this myself. So let's compare a couple things. About 12 years ago, a dentist in North Carolina would earn $25.10 for a D120. This is the periodic oral evaluation. So I wonder if you all know what the reimbursement for that procedure is today. Again, in 2011, it was $25.10. Today, it's $26.96. That's an increase of $1.86 in the past 12 years. Letting that sink in for a second. Almost $2 whole in 12 years for an increase in that procedure. So that's preventive care. Let's talk about diagnostics for a second. So for bite ring radiographs in 2011, the rate was $31.22 for 4 films. Today, it's $33.55. Well, hey, that's a more than $2 increase, right? But again, remember, this is 12 years. So let's look at an extraction. That's a little more complicated, a more complicated surgical procedure, a D7140. In 2011, a dental practice would earn $61.85 for a forceps removal of an erupted tooth. So again, $61.85. Now in 2023, it's $66.44. Now, I'm not trying to claim that the baseline number in 2011 was fair, but if that reimbursement rate for that extraction were keeping up with just that baseline inflation between 2 and 3%, that reimbursement would now be over $80. And this, I believe, this difficulty with the reimbursement rates is the reason I've heard dentists and other leaders in oral health say over and over, we're not trying to get rich off of treating patients with Medicaid. We're just trying to make it possible for us to continue to do this. So I think that you've caught my drift on hot take number 2. Oral health leaders in North Carolina have an ambitious vision for our state in which children have established an oral health home by age 1. People of all ages receive high quality dental services and preventive care and education in their communities, in the languages and settings most welcome to them, in which we use data systems to identify the most effective, value-driven whole person care and provide meaningful feedback to providers and our system as a whole. But we can't do any of this if we don't get serious about financial investment in providers, communities, and infrastructure. And I mean really serious. So I have one more hot take, and then I'm going to move on to something else. It goes back to the word I just used, infrastructure. As an outsider with a backstage pass to this field, when I look out, I see oral healthcare providers who make a multi-generational commitment to families. I see the altruism involved in their decisions, and I see the challenges in our environments. Inadequate resources, racism and discrimination in our communities and in our care, rural areas with deep unmet needs, and of course, lots and lots of sugar-sweetened beverages and other nutritional environments that are not exactly aligned to optimize our oral health. But mostly when I look out at this field, I see innovative, committed, creative, compassionate people working in a system that is not yet optimally designed to maximize their efforts and strengths. Which means that I think we have truly amazing and exceptional people holding up an inadequate system. These excellent people stretch themselves. They turn cartwheels and twist around. They're adapting here and smoothing here and zhuzhing things here because our system isn't yet designed to make their best work easy. We need the system to be shored up so that they can soar. And that's why our task force is serious about the word and concepts of vision and transformation. So if every system is perfectly designed to get the results it gets, we need to start with the results that we want. So I'm going to give you a sneak preview of the task force draft vision. And this is a work in progress, so we're not going to share this widely at this time, but I'm going to share it with you here, knowing that this version is already has comments and changes that will happen to it. So again, this is work in progress, but you'll get it eventually. Thanks, Brady, for putting that up there. So if you can look here at the top in that bold print, the task force has developed a shared definition of high quality care that includes not only clinical expertise, but also the ability to understand and respect cultural differences that affect our experiences of care. High quality to the oral health task force means accessible, and accessible cost-wise, accessible distance-wise, accessible language-wise, accessible special needs-wise. And high quality also means integrated. And high quality also means that there's trust and respect between provider and patient. So if you look at the concentric circles, the NCIOM Task Force on Oral Health Transformation has laid out a vision for what Medicaid beneficiaries, providers, and the system as a whole can do and will do when we achieve this vision. And in this vision, at the individual level, people can access the preventive care, education, and treatment services, right care, right place, right time. In this vision, providers can consistently provide that high quality care. They have the capacity and resources to do that, and they're using information systems that help them integrate with other members of the care team that will give them feedback on their own areas for improvement. And they can hire a well-qualified team, as well as draw on the expertise and support of a really robust network of colleagues that offer both technical and collegial support. And in this vision, our system can provide the resources and real infrastructure to support a culture of continuous improvement, provide data and resources that will catalyze community public health projects to support oral health, that will reward high-value care, and will garner sufficient financial resources to accomplish these goals of quality. Again, quality that's accessible, integrated, culturally attuned, trusted, and clinically advanced. So Brady, you can go ahead and take down the visual now. This is the what. This is what we're going for. And this is an accomplishment in and of itself to have that shared vision, but we also understand that the harder and the deeper part is the figuring out of the how. The task force hasn't finished its deliberations yet, but I am going to share some broad outlines on what we're considering. First of all, the task force is very, very interested in using data to drive the how and the design of what we need to do to achieve this vision. This includes new data systems that will help us understand the current state and navigate smartly that transformation to a better future. This includes from the task force calls for a realistic roadmap, investment, and collaboration to make it possible for oral health providers to share data and information with medical, behavioral, and social care providers. That's right, we're talking about an electronic health record or a platform that can truly integrate and making it possible to do that. The task force wants data on a number of different things. We want data on the oral health workforce, on consumer experiences, on adult services utilization and outcomes. We want data on the health outcomes that are influenced by oral health status, on unmet care needs, and more. These are all very reasonable requests, and I believe that they're necessary to achieve the vision that I shared with you. And also, realistically, if you know anything about developing data systems, all of this is a huge lift. But when we make that lift and we make that effort, they make so much else possible. Good data systems help us to illuminate where our best investments are. They help us create meaningful and supportive accountability systems that eliminate waste, identify problems, and drive real improvement. And as Crystal mentioned just a few minutes ago, there is a really direct connection between robust data collection and better system performance for underserved and marginalized people. The task force also calls for investment in the current and future workforce so that providers can realistically and consistently provide that comprehensive definition of high quality care in all areas of our state. The task force has also developed an expansive understanding of the care team, which includes primary and specialty care, long-term care in some cases, community health workers and care navigators, care managers, and others alongside dental assistants, hygienists, dentists, and specialists. So the task force has a lot to say. It's really more than I can go into here. And as I mentioned, a lot of our work is still in development. But I will mention also that the work of the task force includes many of the recommendations that Crystal just discussed just a few minutes ago from last year's Oral Health Day. We're focusing on things like payment design, consumer experiences, provider supports, pathway development, and more. Some of these are what we realize is that so many of these topic areas cross other topic areas. And right now we're in the process in the task force of prioritizing, of deepening, and of sorting what it is that we feel are the most important recommendations to make as a group. I wanted to share that a real grounding tenet of the task force's deliberations is that we have to be and pay for and support what we want to see in the world in this oral health field. And that includes commitments to diversity in the workforce, supports for people with special needs and for the people who care for people with special needs, integrated care, as I've mentioned many times before, welcoming and culturally attuned practices, and financial incentives that reward high quality care and performance so that we can attract and retain the most talented providers in the Medicaid network. So time's coming up and there's a panel that we need to get to who are going to help to flesh out a lot more of these issues in greater depth. So I'm just going to end by turning back to the wisdom of Aunt Anne. At the end of our phone conversation, her last piece of advice to my brother and me, a few sentences after keep your health, that's number one, teeth are important. She said, do something fun, do fun things together, because that's what it's about. Oral health is about health, it's about prosperity and life expectancy and well-being. But oral health is also about fellowship and connection and feeling like we can pull towards each other rather than pulling away due to oral health pain and shame. Communicating, savoring our favorite family recipes, and kissing babies and loved ones. We're not just fighting for a couple of extra months and years of healthy gums and better blood sugar levels and longer lives. When we're fighting for oral health in North Carolina, we're fighting for what we get to do with those extra good days and good years. And all of that is very much worth fighting for. I'm so glad and grateful to be doing it alongside all of you. Thank you, Steve, and thank you, Crystal.
Thank you, Kathy. That was great. I think our industry benefits from, as you say, an overeducated outsider taking a closer look at what we do and how we do it and the system that we're trying to do it in. So really great remarks and very provocative. I have 100 questions myself, but I'm going to leave it to Hugh and the panelists to help us tease some of those things out. So next, I'd like to introduce Hugh Tilson. Hugh is the director of the North Carolina Area Health Education Center here in North Carolina. The envy of many other states. We have such a great AHEC system in North Carolina. And we're glad to have Hugh at the helm. He is a graduate of the University of North Carolina and the UNC School of Law, so he is a lawyer, and he holds a master's degree in public health from Harvard. Many of you may have known Hugh from his time at the North Carolina Hospital Association, where he started and worked for almost 20 years and ended up as the interim director of the program before he left. But as the director of AHEC, he has really provided great leadership and overall direction for this statewide program, and including all health professions and how we can improve the overall health of all North Carolinians. So I'm really proud to call him a friend and a great partner to the Foundation for Health Leadership and Innovation and to oral health in North Carolina. I'm going to turn it over to Hugh to introduce the panelists. and help us get this discussion going between these other experts we have joining us today. So Hugh.
Thank you, Steve. Thank you so much for that warm introduction. I truly consider you a friend as well, and it's always fun to work with friends. Speaking of working with friends, I would just love to just take a pause and thank Kathy for thoughtful, fun, informative, provocative comments. And I don't know if we can give her a round of applause, but if we can, please do, however we can do that. Certainly great comments and a great way to move this conversation forward. Speaking of, I don't really have the opportunity often to thank Brady, Crystal, and you, Steve, for the tremendous leadership that you guys provide in oral health. As Crystal was describing, certainly made progress, certainly identified lots of other ways to go. And without your collective leadership, we wouldn't be where we are, and we wouldn't have the pathway laid out that we know we're going to need to go down. So thank you so much for your tremendous leadership. I do have the opportunity to introduce our panel, and we're going to run through them in alphabetical order, where they're going to provide us with background on their role, their experience, and those kinds of things. While we're doing that, I'll also remind you, please, to put any questions you would like for us to consider as a panel in the Q&A, so we can focus on those. Rhonda, I'll start with you.
Good morning. Good morning. I am Rhonda Stevens. Currently with the North Carolina Department of Health and Human Services, Division of Public Health, currently serving as the acting section chief and state dental director, among a few other titles. I've been with the program for about 7 years now. And for those who are not familiar with the state oral health program, our contribution to the oral health ecosystem is essentially to serve, if you will, as the dental public health expertise in the state. And so implementing a lot of different dental public health programs and services across the state, including data collection to keep an eye on oral health status across the state, to help support other providers and those who are advocating for oral health in this space. Happy to be here and looking forward to a lively discussion of many topics.
Thank you, Rhonda. Radiance.
Good morning, everyone. My name is Radiance Swanson. I'm the Health Program Manager with Mecklenburg County Pediatric Dental Clinic. I'm excited to be here. Our program is taking off into a different direction. We are hoping to implement a mobile unit in Mecklenburg County. We're also hoping to expand our services to adult dental care. And so there's lots of conversations that is happening right now in the oral health community. I'm happy to be a part of those conversations and also to provide you guys some information and feedback of what some things we found to be beneficial within our group.
Thanks, Radiance. Betsy?
Good morning, everyone. I am Betsy White, and I'm the Chief Operating Officer for Access Dental Care. Many of you know Access Dental Care, but for those of you who don't, we are a nonprofit, standalone nonprofit based here in North Carolina that uses mostly mobile dental services to provide comprehensive care to those in skilled nursing facilities, group homes for those with intellectual and developmental disabilities, PACE programs, community dwelling individuals with special health care needs, and have done a little bit of community health work for medically complex patients and older adults.
Thank you, Betsy. Stephanie?
Good morning. My name is Stephanie Roten, and I'm the Chief Operating Officer at Roanoke Chowan Community Health Center. We are a federally qualified health center organization that provides care, integrated care with behavioral health and primary care services to patients in Eastern North Carolina, regardless of ability to pay. We are setting forward our service line expansion to include dental in Allander, North Carolina. We look forward to integrating dental into our pediatric and adult practices and school base. We are interested in expanding access to dental education and workforce. And so today I am thrilled to take part in this panelist opportunity.
Well, as you guys can tell, we have some great panelists with lots of experience and diverse perspectives. I'm just going to start by opening up to all of the panelists for your reaction to Kathy's talk. What resonated, what struck you, what surprised you, what moved you? I know I was moved by Aunt Anne more than anybody else, but I'll leave it up to you guys. Anybody want to get started with that?
So Hugh, I can certainly address, and first of all, say thank you to Kathy. That was an incredible overview of some very hard work that a lot of people have done over the last, several months. And the representation, I think that's one of the things that people need to understand is this group is representative of all facets, not just dental folks. And so these recommendations are really going to be coming from a broader picture of the influence that dental has on a whole person. And so I think with that, we have to really focus in on the very first thing that has to happen. And I think Kathy did an amazing job of showing the lack of increase in funding that the Medicaid system has had. And there's not a business that's still operating that is still functioning on the same revenue sources that they used in 2007 and 2008. But as you look at these panelists and many that are connected to this webinar today, many of us are. And so kudos to those of you who have persevered and keep going. But we know that that really is the first thing that we have to start looking at is how do we increase these rates so that we can attract more individuals to participate. As we move forward with Medicaid expansion and those things, without increased provider participation, we'll never meet the need. And so to make that first level, that's really focusing on the increased reimbursement and then how we can move forward to create the infrastructure that Kathy talked about.
I was going to make that exact same comment, Betsy. That was the first note that I wrote down from Kathy's comments. It was very sobering, and I literally wrote, the rates are frozen in time. I think we all anecdotally talk about that being a problem, but to have someone share what the rates were, at a certain point in time and how over a decade later, they really have not changed to keep up with inflation, it's compelling. And I to your point that we do currently have Medicaid providers who are doing a great job and they're committed to the cause, but they can't continue to sustain at the rates that are being paid. And so we don't want to take that for granted. But I think that was the first thing that Kathy said that really resonated with me, that, wow, there really is a problem.
And I wanted to take the conversation into a different direction and say one thing that stood out for me that Kathy mentioned is about the interconnected, integrated care, and the fact that as dental providers, we do need to kind of shift our focus to focus on that. We can definitely say it's been a really big impact as far as how dental offices have came back coming off of a pandemic. And I think it's really important that when patients present to the clinic, we not just focus on the oral health care, but the overall care of that patient. One thing that our clinic was able to do within the past year was transition into capturing vital information so that we can understand what is the actual need for this family. So the pediatric dental clinic, we serve children between the ages of 0 to 17 years old. And when that child presents to our clinic, we're checking the blood pressure of that child, we're checking the weight and the height. We want to make sure that the child is within normal limits. And if they're not, we are having an informed conversation with the parent. A lot of those conversations, we were able to identify that those patients are presenting to the dental clinic without a primary care provider. That's a significant thing. So we're here to provide you dental care, but you don't have a primary care provider. So we're starting to create these pathways pathways and this case management process where we're asking the parents, are you experiencing food insecurity? Are you experiencing homelessness? Do you have access to care as far as a primary care provider? And if they identify that they have a need in any of those areas, we have collaborations on partners that we're working with that we've already identified as a referral source, and we're letting that parents know of that information so that child can continue on and get additional services. And that is just one aspect as far as transitioning into an integrated care. So I'm really appreciative of hearing from the medical providers within the county reaching out to us and saying, how can we support you? How can we build this referral base? And then the same thing vice versa. We're reaching out to community partners, figuring out how can we be able to access your resources? How can we share your information? Because we want to make sure that we're providing care not just in our areas, but other areas as well.
Thank you, Radiance.
Ensuring that we address equity, health equity across the board means that we expand access for dental care and integrate as appropriate for our patients, but also remove the socioeconomic barriers that providers face because reimbursement is low. As a federally qualified health center, we have a different payment system. And so our reimbursement shows the disparity and what providers are currently earning to really deliver a high level of care. We must be sure that we look at this through the lens in terms of health equity for providers, those who are ensuring our patients have access to care, and also making dental care affordable. And we have that opportunity with Medicaid expansion to lift our voices to ensure those who are making decisions on our behalf completely understand the barriers in place.
Thank you, Stephanie. So what I'm hearing is money, and that money is an essential element of care so that we can meet the care and care to all in North Carolina. I think Kathy said that she described, or she heard somebody say, we're not trying to get rich treating Medicaid, we're just trying to make it possible, right? And possible is possible for all. So I like to always kind of focus on the patient, start off with that and build out from there. So a couple of things just came to mind about the care you're providing and unique kinds of patient care. So this notion of care management came out and whole person integrated care. Can you all unpack that a little bit more for us? Like, what are you doing? What challenges are you facing? And what are some things that we might be able to do to enhance that? Betsy, you want to give that a kickoff for us?
Sure. Thank you, Hugh. You know, as dentistry sometimes falls behind medicine's trajectory, and I did just a little bit of research, and our medical counterparts have been using care navigation for over 40 years. That kind of blew me away, that it really started back in the late 80s and early 90s, where medicine started using that and realizing that patients that were receiving cancer treatment in a complex system needed that help. Well, when you really think about what that is in relationship to our current infrastructure, how are our patients even managing? And so the idea that we have to support our patients, and Stephanie said it very beautifully with that equity and inclusion and all these barriers that many of our patients face in just getting basic diagnostic and preventive services. You know, it takes that care management team to be able to help them navigate through the system. And whether that be, you know, in an FQHC or community clinic or health department or, you know, nonprofit or even a private practice, there are all these barriers that our patients see, whether they're real or not. But our patients see these as barriers to getting care. And so unfortunately, a lot of times elect not to get care, which then we, you know, as we say in our business, the mouth is part of the body. So then we end up with the effects there. Currently, we use a social worker and 2 dental assistants. In the special care world, you can't successfully treat a patient without care coordination. And so that is something we've had as part of our practice for 20 years. But as everybody well knows, that's not a reimbursable process within dentistry. We really focus on marks on a wall, how many fillings, how many crowns, how many these or how many that. And we don't have a way to represent well that interpersonal connection that we're making with the patient to help them navigate through the system and end up with successful dental treatment.
I know others have thoughts about this as well.
I'm happy to weigh in. So from the point of care coordination, this is a soapbox for me, and that having been within the Department of Health and Human Services during the pandemic response and seeing how community health workers were utilized and became pretty much the superhero of the entire, I don't want to call it a movement, but they really were at the center of helping people get connected to education, to vaccinations, and just overall navigating the complexities of what were happening during the pandemic. And so much as Betsy mentioned that dentistry tends to fall several years behind medicine, hopefully this won't be the same. I think there's an opportunity to use community health workers similarly in dentistry as they were used during the pandemic and as they are with medicine. And so, but naturally with that needs to be reimbursement. And so at the present moment, I'm not sure that it's even reimbursed on the medical end of things, but definitely that's something that has to fall in place to help connect individuals to care. I mean, it becomes an equity issue for all the reasons that Betsy mentioned, you know, all the barriers that patients perceive or that are real. A community health worker or someone the like could help navigate those things for them and get them connected to care. And so I'm all for having those types of individuals work alongside dental professionals, which I believe Kathy mentioned in her opening comments, is going to be critical moving forward. And especially as we get to Medicaid expansion. I mean, there are a number of issues that come with Medicaid expansion, but the demand side of things, part of that could be that patients just don't know how to get to where they need to go or not have awareness of their dental benefits. So having those extra bodies will be beneficial overall.
So this leads to a couple questions that are in the Q&A related to physicians, and the question of why is it that if we need more access to dental care, oral health services, there isn't more integration with physician practices dealing with whole person care, whether that's behavioral health. I mean, you guys have seen the questions in the Q&A. What's your reaction to that? What's your reaction to this question of why do we have this siloed system when the mouth is part of the body, and why aren't we turning to physicians as partners in this work? Anybody want to jump in on that?
I will jump in on that from two angles. So I think the first part, just in terms of physicians jumping in and helping serve in that capacity, I will say definitely in North Carolina, they do that, you know, in terms of integrating oral health into primary care, particularly for young children who are enrolled in Medicaid with our fluoride varnish program. But I think what I see in the chat is more so about really integrating oral health professionals into primary care, which as long as I've been in North Carolina has not really been touched as a topic. And it definitely has in other states whereby you may have a hygienist who works in a OBGYN office, not necessarily providing clinical services, but at least doing screening, education, and helping to get pregnant individuals connected to dental care. And so I think that is a topic that is worth exploring here in North Carolina. I never want to, though, present it as we're unloading all of our dental woes and concerns onto primary care and not addressing our own house. But that is one viable option, is to integrate oral health professionals outside of the dental practice. So yeah, I definitely see that as something that could be discussed.
I think we need to speak to the fact that dental and primary care and emergency care are always working together. And so as we don't speak about it as often as we should, we have providers in the ER who provide the bridge for patients in acute situations and then connect with a dentist. In primary care, here on any given day, we have several calls of patients who have acute issues and are given pain management and antibiotics until we can get them referred and seen by a dentist. What we could do to expand that care is continue the conversations and expand the services to include more integrated care. RCCHC will be opening an integrated primary care health center in Orlando, and that is a first step. And we're also housed with ECU dental residency right next door. And so let's call out the good work we're doing. And I agree with Dr. Stevens, like, you know, we are going to move forward and continue to address the silos. We know they're there, but also we are working.
And I did want to come here just to provide feedback and information to those that are interested in tapping into the care management within your dental organization, your FQHC. I think it's important that you consistently tell the story. We know that there is still some uncertainty where Medicaid inspections will have an impact as far as the dental world, but I think it's important that you consistently try to implement new processes within your programs or your organizations and track those newly implemented processes. So for instance, right now we know that the care management code isn't something that's reimbursable, but that is something that we consistently offer to patients. And we are ensuring that this is something that we are billing to Medicaid so that they're seeing that these services are being provided. We track that internally because we want to tell the story. If we're referring individuals to specific referral sources, it's important for us to evaluate those sources. Are we completing the referrals? We see patients at minimum every 6 months, but once that patient returns back to the clinic, you're determining, did you follow up with that referral? Were there any bumps that you experienced in that process? This helps us determine those social determinants of health that we're all talking about and access to care by referring and seeing if those referrals are being completed in a timely manner and ensuring that your community partners are working to help those individuals. That just helps you to be able to have like a bigger picture as what's going on in the current environment. I think it's really important that we continue to be a support to those medical providers. I know that a lot of organizations do not have the integrated, interconnected system going on, but if you go out and you reach out to those providers and you build those relationships and you implement those programs, that's something that you can be able to track internally, report to Medicaid if needed, so that as we're having those discussions about Medicaid expansion, this is something that they can consider in the future.
And I want to follow up, Radiance. That was a wonderful explanation of the process. But it's also about education and how we integrate care. And yes, one of the things I wrote in my notes is y'all, this is a marathon. We're not going to turn a switch tomorrow and have, even if the day the recommendations are released from the IOM or, Medicaid makes a change here or there, we're in this for the long haul. And so, one of the pieces of the puzzle is that continual education. I recognize a lot of times when we're in a nursing home and I'm trying to help a nurse understand what's going on with that patient from an oral health standpoint, she'll turn around and look at me, or he'll turn around and look at me and say, you know what, I got 1 hour of oral health education, and it was after a midterm exam. And so, we get sometimes frustrated with the lack of the integration. We have to be part of the solution too, as we continue to educate and reach out across those silos to help everybody work together. And yes, I do eventually really believe we will have a better integrated system, but that is going to take time. And so what, I always look at a presentation is what can I do tomorrow when I leave a lecture or a CE event? And that's what you can do tomorrow, is to start talking to your medical colleagues. And I know a lot of you already do this, but have those open conversations and how you can benefit each other, because that's how we will drive change.
I love that. Thank you guys so much. And I'm just going to quote Kathy again. The way she described the current state is exceptional people holding up an inadequate system. We need to shore it up so they can soar. And what I hear you saying is, while we're working on that, let's make sure we're communicating as best we can. So we're collaborating as best we can, which I think is awesome. Rhonda, I think you mentioned Medicaid expansion. Let's just turn to that if we can. And how do you guys think Medicaid expansion will affect your work? And what are lessons we can learn and things we need to be thinking about as the state moves forward with that?
Sure. I think we're all probably at least have one common concern in mind, and that is just provider capacity to serve the potential 600,000, adult beneficiaries that will come on with expansion. But I think it's twofold. So, right, we're talking about supply, and that we currently struggle right now with adequacy of the provider network. Even those that are technically considered Medicaid providers, they're not always accepting new patients. And so those are definite concerns. But I think the other piece of the puzzle is we can't really say for sure that the demand will be what we think it will be, for a lot of the reasons we've already stated. So one, there might be a lot of beneficiaries who don't even recognize that they have dental benefits. And so making sure that that's crystal clear. But then just the ability to navigate to find a provider who's taking patients that month, that quarter, that day, having that extra workforce, whether it's a community dental health coordinator, community health worker, someone to help navigate to make sure the supply gets to where it needs to get to. Or I'm sorry, the demand gets to where it needs to get to. But I think it's making sure we've got providers on board. And I think we've enumerated the issues with the network, and those are not quick fixes. And so if the budget is passed, I can't say what things will look like. I think it will be slow, for patients to start seeking providers. But what do we do once they do start seeking providers? That's a huge question mark.
Anybody else want to comment on that? I hear a couple things in there. Number one is awareness, and how can we make sure that patients that have this newly found access are aware of that. And I know that the state is working really hard to work on a communications process. And I think making sure that oral health providers are part of that is going to be an important piece of that. So I'll be sure to raise that next time I'm on one of those calls. And I think Kathy, you're on those too. So remind me to raise those if I don't. But you also mentioned supply. So let's talk about supply and the workforce and what's going on. When I think about workforce challenges, there are two elements, or there are multiple elements, but one is retention. And there are lots of people who are really tired, come out of the pandemic and trying to figure out kind of how do I keep this up in this new environment. And the other is building the workforce for the future, developing that workforce. Let's talk first about kind of sustaining the workforce. What are y'all seeing in your settings, and what are you trying to do to help the wonderful people that are, what did Kathy say, exceptional people holding up an adequate system? What can we do to help them?
Yeah, I can definitely attest to the fact that the pandemic has played a major role in the lives of your everyday workers. So a lot of people are looking for convenience and flexibility. And I think as organizations, we have to tap into that work-life balance that our candidates and our employees are interested in. So having those flexible hours, I think, is something that's really important. I noticed a lot of organizations have transitioned into a 4-10 schedule, longer weekends, obviously longer day, but that helps impact the employees that are working because they have that opportunity to spend a lot of time with their family that they've spent very long hours with over the pandemic. So just imagine your team in terms of having that opportunity when the office was closed and we weren't able to kind of work one-on-one with our patients because we were still trying to figure out what's happening with the COVID and the pandemic. They spent long hours with the kids and families, and to have to jump back into a work field and have those long hours that you have to work with and the less opportunities to spend with your family, that's something that really impacts. And we lost a significant amount of oral health professionals returning from the pandemic. And I think they're all speaking to the fact that work-life balance is something that they really are interested in. So if you're focusing on retention and you're also focusing on recruitment, I think having flexible hours to offer to your employees are something that they will be able to benefit from. And then on the flip side, it's something that you can be able to offer to your community, because longer hours for those average individuals that are unable to make it to you within the work hours, you have early hours that you're able to offer services, and sometimes even late days as well.
Also focusing on the pipeline, we understand we need more allied health professionals, dental hygienists. It's very difficult to hire right now. Also, dental assistants. And so connecting with our schools and the early college programs at our high schools to expose students who may know very little about the dental profession, but giving them exposure so that they can see the possibilities and opportunities. Additionally, for organizations, registering to become an apprenticeship employer is very important so that we are able to grow our own. We have staff who could upskill to become dental hygienists and dental assistants and practice managers. And if you look at the total composite of all occupations needed to support dental, we have opportunity right in our own houses. And so leaning into community college systems, apprenticeship, and also taking wellness very seriously and adding it as a component to our processes with our HR partners, and also listening to our staff about what their needs are. Because if we are able to provide wellness and opportunity to decompress, that's dedicated time, then we can retain our staff.
And I'll speak just a little bit on that pipeline issue in the education. Is I think right now we have had the opportunity and are continuing to have the opportunity to really look at dental education as a whole. What's happening in our dental schools, what's happening in our dental hygiene and dental assisting programs, what exposure are they getting, especially as this group represents a lot of our safety net providers. You know, what are the experiences? What are the things that they're being told and taught, and the perceptions that sometimes they get early on in the education process without really having the opportunity to get to be boots on the ground in those environments. And I know right now there's a Senate bill that's looking at some opportunities to be able to open those doors a little bit to get students more into the hands-on approach of some of these more specialized care areas and public health arenas. And that's been a possibility, but you know, research shows you send somebody on a 2-week rotation and you're more likely to turn them away from an experience than attract them to an experience. So to be able to identify those students early on, you know, we call ours the special care gene. If I can get hold of somebody at the very beginning that I know has the special care gene and nurture them through the education process, then we've created a pipeline that's going to fill a lot of empty spaces for all of us.
I think in addition to that, going a little bit further back up the pipeline is for undergraduate students. I find that I really enjoy talking to undergraduate students before they've identified a trajectory. And so aside from just talking about dentistry as a career, I'm talking about public health as a potential undergraduate degree, because I'm trying to change how they come into dental school, the mindset. And so if you've got a public health mindset, you understand social determinants of health early on. You understand behavioral health and why someone makes this decision versus this one. Before you get the dental education, maybe that sends you on a different pathway. Maybe you're more likely to practice in a safety net setting. Or maybe when you go into private practice, you are that much more passionate about trying to figure out how to make it work, meaning see Medicaid patients as well as be in private practice. And so I think those are the conversations that I've started to have and that I hope others will start to have. And that is, it's not just traditional biology, chemistry, the science majors and things like that. You can do public health as a viable undergraduate degree before you go, before you go to dental school or to hygiene school. And I think that just sets up for a better dental workforce. And so that's what I'll be pushing.
Rhonda, I absolutely am happy that you touched on this. I think it's really important that you nurture the foundation before they enter the field. We all know that dental public health is completely different than what you are going to experience when you work in a private practice. And it's important for them to know that you have to start thinking upstream, right? How do I prevent the child from, or the adult from entering my clinic with the issue that they have? And then another important factor that you have to consider after all of this is Carrie's risk assessment, perio risk assessment. What are you truly trying to identify when you're doing those assessments? And I think it's really important that we're starting those conversations, building those relationships with the community colleges, with the universities, and with the dental schools, so that you're introducing the conversation very early on, so that when they do start to process and think about if this is a field that they want to enter in, they're coming in with the, the strong mindset and understanding what am I here for and what is my purpose. One thing that we found to be really important, and I know that Betsy, you guys just touched on this as well, is early on providing support to those schools as well. It has to be a mutual relationship, like with anything in life. And I felt it was really important for us to be able to support the community colleges that have dental assistants that are trying to graduate by providing internship and hours, and same for the dental hygiene schools. So recently we just built this relationship with our local community college, where those hygienists are going to rotate through our dental clinic. And my hope is, okay, you have a class of 15, maybe out of those 15, 2 are interested in entering to the public health field. And if I don't have a position available right now because we're fully staffed, which would be a great thing, at least I know that I'm filling the vacancies within another organization that is experiencing some workforce challenges. So I think it's really important that we're doing this with a mindset of not only just being able to support our organization, but to support the field in general. We're all here trying to solve the same thing, and we have to work together. So if everyone is kind of putting those muscles towards the nurturing of the relationships, and even as young as high school students, we have 2 interns that are with us for high school that are coming into the dental clinic. First day, they said, I don't know what I want to do. I don't know what I want to study. But by the time we went on some ride-along, some shadowing, I have one that's already interested into dental hygiene. So this is what I'm talking about, just having that opportunity to expose those individuals into an environment or field that they might not be aware of, that will be able to benefit us all.
This is a great conversation. And as the AHEC director, I love to hear it. It just sings to my soul. One of the things that we believe is that, and I think the data show this, is that patients tend to respond when their provider reflects them, when they see themselves either through physical or through lived experience. So building a pipeline, a pathway into health careers generally, and oral health specifically, for that equitable population. What do y'all think we can do better to help drive that?
I'll start that. So I think one thing I will say for sure that from a public health standpoint, what the Department of Health and Human Services is doing a lot of intentional recruitment and internships with HBCUs in North Carolina. And so even though I don't have any interns from HBCUs in our oral health section program, I still go out and I speak to North Carolina Central undergraduate students, and I'm talking about public health and dentistry. I'm trying to get both things into one. And so I think doing more intentional education, recruitment, pipeline efforts, where you need providers to come from, is first and foremost. And so there are health careers opportunities programs, a federal initiative that I believe still exists. I came through one of those programs when I was an undergrad, and it was geared towards disadvantaged students, whatever the background may be, to help introduce them first and foremost to health careers, but then secondly, specifically to dentistry. Went through 4 years of that program, turned around and served as a mentor, and then you just keep moving and you reach back to those same types of programs, but there needs to be more of those programs at dental schools or community colleges to implement those programs. And so, if funding at the federal level is drying up, then that's something that needs to be advocated for. But then to have our dental schools within North Carolina to actually request that type of funding and implement programs, and it's not just limited to undergraduate college students. It could go, like we said, to high school and to middle school students, but you have to be intentional in who you're reaching towards. That is just the bottom line of it.
I agree, Rhonda. I think it's really important for you to be able to meet those individuals where they are. I think it's important for you to provide that education and guide where they can be able to kind of navigate. I think for me, I came from a really small community and from the US Virgin Islands, and it's really important for you to be able to provide that education and that career path so those individuals can know that those are possibilities. Like a lot of times individuals, they attend college and they think that certain things are unattainable due to financials and costs. And I think it's important for you to be able to provide that education of what programs are available that they can take advantage of, what services that they can be able to end up to see tuition reimbursement as a possibility as well. It's just really important, and it comes down to the education. I'm sure a lot of these students, if they think that I would not be in depth if I do certain things to be able to navigate the system, they will be more interested in that, because no one wants to spend thousands of dollars for a college education and not have the opportunity to be able to earn those funds back, or even to find a job at the end of the day. I think it's important for you to be able to provide that guide and that support. And this is where it ties back into working with those universities, working where you are going into some of the high schools or going into some of those community colleges, and just educating them on it is a possibility, and by following these specific steps, this is how you can attain and reach that goal. So education, really, really important, and providing resources and working where you're having grant opportunities available for those individuals to take advantage of. I think that's important as well.
And to piggyback off of that, representation matters. And so in hiring practices, ensuring that representation is at the table so that there are equitable hiring practices and assessment of qualifications and resumes. Team-based care model really embraces the whole component of having a diverse workforce. And so giving some of the hiring power to the team so that we can have representation to care for our patients is important as well. And also ensuring that we have those partnerships and community resources to help to engage in hiring practices. I'll use the example as we look for a dentist to support our new service line, a chief dental officer. We're leaning on partners to help us in the interview process so that we ensure that we are providing each candidate with a fair opportunity, as we don't have all the information ourselves and the expertise around that. So representation matters.
Those are wonderful comments. Thank you. I want to kind of piggyback on some of that in team-based care and kind of transition a little bit over to legislative and regulatory changes. There have been some advancements in hygienists' ability to meet needs, especially in some of our most marginalized communities. As y'all think about access and you think about team-based care and you think about leveraging scarce resources, what else would you like to see being thought about or being developed so that we can maximize these scarce resources and utilize our personnel to the greatest possibility?
I'll chime in. I think we have great opportunity in expanding teledental services. And so being able to provide virtual care and getting actually reimbursed for that appropriately across the board is an important step as we contemplate expanding access, and especially with Medicaid expansion. And it's also important to understand the dental relationship between the hygienist and the dentist's capacity to supervise. I think we're at a point where we should look at the regs again and understand supervision and what that should look like across practice, and especially in public health.
And I'll add to that. So I think one thing that is easy to do that I don't think is contentious is that we've got current provisions, you know, for those who are not fully aware of all the Dental Practice Act provisions, but provisions for public health hygienists, and then provisions for basically hygienists who work in private practice to be able to work without direct dentist supervision. But those provisions don't align in terms of prior experience, training, reporting requirements, but they effectively were designed to do the same things. But one has a more strict pathway to get to it than another. And I don't think there's any historical knowledge as to why that is. So I think that's an easy fix, just making sure that whether you're working in a public health setting or in a private practice setting, that you're still able to work without the direct supervision and everybody has the same requirements and reporting structure. So that's one thing, is to align those provisions. I think that what came up earlier, and that is, has North Carolina ever explored the idea of a hygienist working under a physician? I will jump to say probably not, because we've been trying to make just incremental steps in the provisions that we do have before we jump to a completely new profession. But if we're talking about a limited workforce, you know, those are ways that we could definitely be more efficient in using them. While we work on increasing the quantity of them, I think there's ways to improve access by allowing them to do a bit more than what they currently do. And those are just two examples.
Rhonda, I think you bring up a great point about some of the alignment. And as most of us are aware, the Dental Practice Act was written in many different pieces and parts and different players and those kinds of things. And I think, you know, really, you know, part of the holdback is some confusion. You know, can I do this? Can I do that? You know, and we have those conversations with some of our partners. And so, you know, that alignment of really looking at the Dental Practice Act, and I'm getting ready to say something I might not ought to, but looking at it from patient-centered care models, you know, of how do we best take care of a patient, and then how do our laws and regulations line up to that? And allowing everybody to work at the top of their licensure to be able to meet the needs of the patient.
I love starting with the needs of the patient, right? We started this panel with the needs of the patient because I think at the end of the day, that's why we all do this, right? We're all doing this to try to increase the health of the people that we all care about one way or another. I forgot what I was going to. Oh, I did want to mention, Dr. Stevens, Rhonda, there's some great comments in there about your observations. So if you haven't looked at the Q&A, please do. And Radiance, I think they aligned very nicely with the comments that you were making as well. We got a question somewhere about rural as a specific need. And I know some of you are from rural communities. As you guys think about rural communities, are there unique approaches that you want to raise up that might be helpful?
In rural, it's rural public health, dental care delivery, and primary care. It is very important to meet our patients where they are. And so that's with understanding that whatever reason that they decided to establish and enter into care on a given day is the day that we embrace their courage and expand their understanding through the fact that they showed up is just a great step. And so in rural, transportation continues to be a barrier to care, Medicaid expansion, and the needs to have greater access to coverage, barrier to care. And so as we try to educate and grow our patients' understanding, we never try to speak about, you know, the delay in care in a way where patients may receive it as shame, or we discourage their effort. We embrace the connection. And so we move forward from that day on. And that approach has made it very possible by word of mouth that other patients come because of the respect. The other thing I'd like to say about that is embedding dental screening in our pediatric department that's very thriving gives us opportunity to have a twofer. We can change the trajectory and legacy of entering healthcare by giving early education to parents and guardians. So their children and those they care for, our littlest patients, may have a different life experience. And so those screenings also give us opportunity to tap into exposing their parents and guardians to dental screening as well. And so we are looking forward to being able to change outcomes of families in our community by starting with the smallest of our patients.
Stephanie, I just want to echo that respect and dignity piece and that relationship. And unfortunately, that's rural and urban areas of the state, but especially in rural communities where you have to build a trust factor. And even going outside the silos of medicine and dentistry, or who are those other players in the community that you need to bring on board? You know, are there faith-based communities that can help be your voice in that community, that trusted voice in the community? You know, are there certain ethnic groups that gather together under different provisions that can help be another trust factor in knowing that when they come in, they're not going to be shamed, they're going to be treated in a respectful way, and that we're going to listen to them. And we're not always, I mean, we're going to tell them what the options are, but, you know, one of the things patients say to me a lot is, you know what, because I'll ask the question, tell me what you want at the end of the day. And then for them to be able to be given that opportunity, that we're not telling them what treatment they have to have. They're telling us what treatment they want. And then we figure it out in the middle. And I find in rural North Carolina, there's just that extra layer that you have to work through, and it's a soft layer that's not always, you know, real prominent, but once you kind of start working in that layer, you realize when you give them permission to be part of the process, how much they appreciate that.
I agree, Betsy. Personalized care plays a key factor in the success of those treatment plans and the success of those relationships in rural counties. This is where those community partnerships that play a key role in keeping that relationship strong and nurtured. A lot of times you may find those community partners may help fill those gaps that you're experiencing. So if transportation is an issue, some community partners, knowing that those members need that support and they need those services, will possibly provide transportation to and from your office. I found recently with Title 42 ending and dealing with a lot of the migrant populations that have been coming in, those community partners have definitely stepped up provided support, some during that education process, or as we're talking through those treatment plans, they have those community partners that they lean on and have the trust factor with. But those community partners, due to those positive relationships with us, have continued to stress that the importance of oral health and the importance of them keeping up with that care. A lot of times it's really due to lack of education and as it relates to that. And those are where those relationships and nurturing those relationships are very key in the success that you will want to experience.
So Radiance, you have touched on a million things that I love, and I keep wanting to talk to you offline. So maybe I'll get to after this, but one of many things I've been harping about is something you mentioned about not just integrating oral health into primary care, but integrating primary care into dentistry. And that's how I'm wording it. And that is blood pressures. I saw someone ask a question about, why was reimbursement the reason why dentists don't check, A1Cs and things like that. It's a lot of reasons. It's not just reimbursement. But we, and I'm collectively saying we as dental professionals, don't do a good job of integrating the body into the mouth. I'm just going to say that. And so aside from that, like things like blood pressure and A1C, having the knowledge, which means it comes from your training, to understand what is the social determinants of health screening? Why do I need to do that? Should I just be concerned that this patient missed an appointment, or do I actually want to investigate so that I can potentially help them address the issues so that they can be compliant with a treatment plan or show up for an appointment? And so thinking about whether it starts at, well, not whether it does, but starting from your dental education, whether it's assisting hygiene dentists, through continuing education, training providers to look at more than just oral health and their technical skill set. Like, how do you focus really on whole person care rather than, like I, crassly say, us unloading all of our dental issues onto another profession? What can we take ownership in? And part of that is just doing better at looking at social determinants of health. And FQHCs and health departments are naturally set up better to do that. But the safety net is only this big compared to the vast majority of dental providers. And so how do you get others on board with doing that? It doesn't mean you have to be the person to counsel someone or actually connect them to a Medicaid enrollment specialist, but know the resources available in your community. Enroll in NC Care 360. I'm not sure why that's not going as well as it could be, but it could be, right? It's set up for everybody to be involved: social support services, healthcare professionals, and the patient population. And so I think as we talk about a lot of workforce issues we're dealing with, meaning we have an opportunity to train up a whole new provider pool, as well as train those who are already in the pool. But as we're in this very awkward space, I think it creates a huge opportunity to do things very differently and us start being more integrative rather than us always talking about integrating oral health elsewhere. And so those are things that you are definitely doing in Mecklenburg. And so applaud you for that. But I think it needs to expand beyond the safety net to private providers. And that's a huge lift, but another one of my many soapboxes. Yeah.
So we've got about 10 minutes left, and I think now is the time that I invite Kathy to join us and kind of say questions for panelists as well as Kathy in response to her wonderful presentation. While we're waiting for those, let me just, Kathy, ask you if you have anything that you wanted to respond to the just wonderful conversation we've been having in the panel.
Yeah, a couple things come up. One of the things that I have found kind of interesting about the whole experience of working on this is what people mean when they say public health within the oral health space. And one of the things that I've learned is that sometimes when people say public health, what they're still meaning is clinical practice, but they mean clinical practice for a wider range of accessibility. And I understand public health, and I'm not trying to be judgmental about how people use the term public health, but I understand it a little bit differently, that it also relates to things like nutritional environments, that it also relates to those big structures and systems. And one of the things, and this is your work too, Rhonda, in DPH doing that oral health work. And one of the things I realized as a public health practitioner at a local and regional level for a long time is that I wasn't connected to oral health work. I didn't honestly have oral health data on my community so that I could know where to act on that county level or regional population scale. And not everything has to always start with data, but we did have, for example, questions about water fluoridation, nutritional environments, and those types of things. And I see that as one of those opportunities on the roadmap moving forward, is how do we get this whole body of work more connected to that local public health, that county level infrastructure that's thinking about public health, that includes both shoring up the safety net and those types of things, but also about those larger environments that really have an effect on the outcomes too. Different way of getting to the outcomes, but an important thing to consider. I had a couple of notes. So one of the things I wanted to say, I loved, Hugh, that you were quoting what I was saying about exceptional people holding up an inadequate system. And then I started to think, well, I want to make sure that our North Carolina Medicaid leaders understand themselves to be part of those exceptional people. I think we really do. I just want to make sure, for example, Mark Casey and Darlene Baker are so deeply trusted. And I want those folks and other Medicaid leaders to understand we all have a role in the fixing of this. They're not the system. There's no villains here, right? It's really this much, much larger system of how these things get funded and what we do with our resources. And I think what I've observed is that we really have people going above and beyond, because our system isn't built, like we said, to make that exceptional work just the way that we've designed things. I think that question, I think Dr. Moss asked a question in the chat specific about rural healthcare providers, and how do we, I probably need to look more specifically, and it might be one of those answered.
I know I moved it out so that we could pay. Sorry.
It's okay. It's okay. One of the things that we would just observe again is we've got a system that's designed to get the results that it gets. And one of those results is an intense maldistribution of providers and practices. And if we want to change that intense maldistribution of providers and practices so that we have more rural providers, then we're going to have to create incentives, supports, pay, and other rewards for people to be out there in those places. And I think sometimes we have a system where we just expect those things to happen. And what we've seen is that when we just expect it without there being more intentionality to saying this is a goal and what are the strategies to get there, then it doesn't just happen, right? And I know that there's some programs, but I think there is the identification of what gets people to those places, keeps them there, and so on. And I think as we've heard people here talk, it's also about early exposure. It's about realizing how strong the quality of life can be in our rural areas, and helping people to learn and understand that. Those people that come from those places, those people that may come from other places as well.
Cassie, can I just pause you for a second? Because we're going to run out of time.
Yeah, stop.
And I want to make sure that in the last 5 minutes that we have, any of you guys that may have something you want to make sure gets said before we run out of time, you've got a little bit of time to do that. So let me just throw it out to you guys. What didn't you say that you wanted to make sure this audience heard?
I think the important thing to stress, and I can't not remember who said this, but always remember it's a marathon. Like, we have so many ideas, we have so many problems that need to be addressed, and we only can encounter it one at a time. And I think it's really important for us to know that there are going to be some wins, there are going to be some losses, there's going to be some moments where what we thought was going to work did not work, and we do not give up. Remember that working and continuing to contribute to the oral health community, I think it's really important. Someone said in a chat, like, what can we do, right? Data is something that's missing. we need to tell the story. This is why we shouldn't just focus on the fact that it's not being reimbursed, but still continue to report, still continue to track those numbers, because those numbers tell a story, and that's the story that's needed to be heard. And having that data, not just quantitative data, but also qualitative, have a story and have those case studies so that you can be able to share that amongst your oral health community, so that we can be able to determine what is needed and what we can do as a safety net community, as oral health community, to create change.
We have 14 dental hygienist programs across North Carolina without evening, weekend options for access to education. So if we could expand the education access, we can also increase the pipeline so that we have greater outcomes for our patients. And so if we could just think about what we are currently doing and expanding that to include evening, weekend options at our community colleges.
I think Aunt Ann is the star of the show today. And you can tell her we said that, Kathy. But you know, from Aunt Ann's insight, your teeth are important. And we as dental health professionals sometimes get tunnel vision. And it's all, I mean, you know, we say all the time, dentists think in millimeters, hygienists think in millimeters. And to be able to take that huge step back and realize the population that we are drawn towards, that we feel led to serve, and being able to address whether it's rural versus urban, whether it's systemic health and oral health, you know, connections. But then, you know, we have this whole behavioral health, and that hasn't been said yet today, is there's this huge behavioral health population that is really, really struggling. And so how do we help, and to use Rhonda's words, how do we help get to them? It's not their problem to solve. How do we help get to them to be able to meet them where they are, and to be able to understand that mental health, oral health connection? And when you can't smile, what does that really mean at the end of the day?
Rhonda, did you have anything you wanted to add? Just want to.
No, my final thought was really my biggest final thought, and that was oral health professionals stepping back and thinking about more than just their technical skill set and things like that. So that was my parting thought.
Gotcha. Well, Steve, I'll turn it back over to you. But before I do, let me just, oh, actually, Kathy, did you have a final thought? I don't want to, okay. So I'll have a final thought, and that is that in today's world, it's so easy to get bogged down in all of the crap. This panel today is so uplifting, and just hearing the wonderful thoughts and the passion and the commitment to helping patients navigate this system, including you, Mark, to really make it better is just so uplifting. And I'm glad that we had this time together. I appreciate all that y'all do all day, every day, and to carve out some time today to help us understand your world and how we can all work collaboratively to advance it better. So thank you so much for both what you do all day, every day, and for being here today. Steve? Yeah.
Thank you, Hugh. And thank you to everyone as well. I have taken pages of notes, and to Hugh's point, this is a recorded event. So if you heard some things and didn't think you got it just right, and there were some clever quotes that you want to use, please feel free to go back to our website and listen to that. I'm going to make a feeble attempt at trying to hit some of the high spots that I think we heard over and over again. And I'll start with Kathy, and so thankful for her hot tips about teeth are important, about fees are a barrier. They are necessary but not sufficient, but we are living in the past with our fees. And if we want providers to provide the kind of care we think our citizens deserve, we've got to deal with that. And infrastructure, and those exceptional people holding up an inadequate system get tired, and we've got to build the system that supports that better. kudos to the task force for creating a vision for what good quality oral health ought to look like in North Carolina for all of our residents. Unfortunately, designing the ideal is a lot easier than building to it. But as we've heard, there's lots of good ideas, and that this is a marathon, not a sprint, and that we need to pick those off one by one and start moving in the right direction, develop that roadmap. And I really feel like the task force report is going to help us do that. So glad that's going on. I also heard a lot of focus on system changes, not just millimeters and individual patient cares and what this provider can do versus another. So system changes has got to be part of our roadmap to the future. Workforce issues, fees, collaboration in particular. I heard a lot about working with community partners, working with our pipeline for dental students and other healthcare professionals, and an acknowledgement that that's a two-way street. We've got to build a system that works back and forth on that. And then lastly, I heard a lot of discussion from different perspectives about the need for a fully functional oral health team, a group of providers working at the top of their license, and maybe some providers that we don't yet utilize in North Carolina to help us have the most efficient and effective workforce for better oral health in North Carolina. So those are just my quick snapshot of a few highlights of today, but this has really been great. I want to thank our speakers and panelists and Hugh, the moderator. I also want to thank the Oral Health Collaborative team for all they did to help put this on and make it a success. And lastly, this wouldn't be anything if we didn't have you as the participants and sharing your questions and your ideas and participating today in this conversation. It's been really helpful. There was I saw a number of questions come across, and I'll make one last point, and that was about people frustrated about finding access to care. Just a reminder that the Oral Health Collaborative does maintain a list of access and free and reduced care clinics in the state. So does the oral health section under Rhonda's purview. So if you're looking for care, please know there are some resources there to do that. As a reminder there, I'll say these volunteer clinics and low-paid providers are not a sustainable system. So I'm really hoping you will join with us in a call to action to build a better system in North Carolina for oral health care. Thank you all for being here, and I think we are done for the day. Thank you.